We'll move ahead to my friend and colleague from Connecticut, Mark Vitale, who's going to give us 2 talks today about collagenase. The first one he'll explain.
All right, thank you very much. No relation to our last speaker, as far as I know, although I do have family in Rome that I'm going to visit on Sunday. So this first talk, I wanted to talk about, first I'll just mention disclosures. I was on the advisory board for Endo Pharmaceuticals, which is the company that makes Xiaflex, and I'm a consultant for a small medical device company called Raphael Medical Devices. So the impetus of this simple study was, we all know there are treatments that are effective to treat contractures when they develop, namely different surgical techniques of fasciectomy, collagenase, and needle aponeurotomy, although the recurrence is variable and very common. And when you look at the literature, it's very difficult to predict the relative durability of these treatments because the existing published studies are largely retrospective. They have very small sample sizes. There are studies with 5 or 6 patients. There's short follow-up times and inconsistent definitions of recurrence. So really what I wanted to be able to solve was when a patient would come in and we would talk about surgery, NA, or collagenase, and they would say, "Doctor, what's the likelihood that this is going to come back?" And instead of saying you have between a 5% and 90% chance of recurrence in 6 months to 10 years, I wanted to have a better number. So we hypothesized that limiting review to high-quality prospective data with minimum 2-year follow-up, we would find that surgery had the lowest recurrence rate, needle aponeurotomy would have the highest, and the joint treated would matter. So we performed a systematic review of prospective studies or randomized controlled trials treating Dupuytren's contractures with either fasciectomy, collagenase, and/or needle aponeurotomy, minimum 2-year follow-up, and a strict definition of contracture recurrence. We looked at 4 available databases and a variety of search terms, and we then searched all of the identified papers reference lists to review additional relevant studies. The inclusion criteria included prospective series or randomized control trials, treatment of contractures with fasciectomy, NA, or collagenase, minimum 2-year follow-up, a clearly defined and consistent threshold for contracture recurrence. Typically, it was the 20-degree measure. And then having available data on recurrence at final follow-up and a minimum sample size of 15 patients. Exclusion criteria were those not published in English, those lacking recurrence definition, no follow-up recurrence data, or studies with less than 15 patients. And the primary endpoint was contracture recurrence as a function of treatment type and joint treated. Secondary endpoints looked at reinterventions and treatment complications. So using these criteria, up until 8 months ago, there were only 9 published studies that met the criteria, although we heard some studies today that need to be included in this. So of these 9 studies, there are 1,127 patients, 1,250 joints. Most patients underwent collagenase, followed by needle aponeurotomy, and the most poorly studied group is surgery. The follow-up ranged from 2 years to 7 years, but the median follow-up time was longer for fasciectomy than collagenase or needle aponeurotomy. So there was a representative population, mostly male, average 66 years old, variable reporting of comorbidities in these studies, and the majority of joints treated were metacarpophalangeal joints at about a 70 to 30% ratio to the PIP joint. So this is sort of the take-home point of the study. If you look, let's see if I can get this to work. If you look at the far right column on the table, the recurrence rate, when we looked at these 3 studies, the highest recurrence rate, this is at a median 4-year follow-up, was needle aponeurotomy. 52% of patients had recurrence. Collagenase had about a 35% recurrence, and fasciectomy had a 22% recurrence. So statistically comparing odds ratios, there was no difference in collagenase with either needle aponeurotomy or fasciectomy, but comparing needle aponeurotomy, there was a 5 times increased likelihood of recurrence compared to fasciectomy at the mean follow-up of 4 years. Now, the collagenase group had a high number of patients, but there was high variability, which may have prevented the detection of a significant result. So we also found, as many other studies in the past have shown, recurrence was lower for MCP joints versus PIP joint contractures. They were about 2/3 less likely to recur. So the patient on the left is going to be less likely to recur than the patient on the right. Looking at reintervention data, the data was not very good in these studies, but 6 studies reported on reinterventions. For fasciectomy, 4 out of 5 recurrences were reoperated on. For needle aponeurotomy, 3 out of 5 had a reintervention, and for collagenase, 39% had reintervention. Treatment complications, the data is very hard to compare between studies because one study might list pain, another study may use the term discomfort, one study may say swelling, bruising. There's a variety of different terms, but the most commonly reported complications across all studies were digital nerve injury, skin tear, pain and swelling, and some sort of bleeding. So the limitations of the systematic review were that even though we had a minimum 2-year follow-up, it was still relatively short follow-up times. The max was 7 years to really make a useful statement. You'd like to have 15-year data, but that will never be done in our field. There were low sample sizes in the surgery group. There was a lack of uniformity of treatments. Some needle aponeurotomy studies had corticosteroids, some had lipofilling, and there were different fasciotomy techniques. Also, even in these studies, there was a lack of consensus of the definition of recurrence. But in conclusion, although the current published literature is imperfect, the results hopefully will inform the surgeon-patient decision-making on the relative risks of recurrence of the contracture. Future studies should seek longer-term follow-up data and a consistent definition of recurrence to best compare the durability of maintaining extension between these treatments. This study had no funding, and I'd like to thank many of the people here who've taught me a lot about Dupuytren's. Thank you.
Thank you, Mark. I mean, one thing I find disturbing is that in 2012, Paul Worker and I, with Von Riesen and Denkler, wrote a paper defining recurrence, defining follow-ups, and this has been, there's a great review, meta-analysis you did of papers pretty much that was subsequent to then, and it's still apples and oranges comparing, which makes it the most difficult part of analyzing results of Dupuytren's is not having some standard definitions. Thank you very much for bringing that up. Any questions for Mark? Right ahead.
If I understood correctly, with one arm meta-analysis for all the treatments, we didn't pull the right to. So one thing I was thinking that when you have prospective, not comparative studies, so then the indications might not be the same as in the randomized control studies. So that's why I'm thinking your estimate might be underestimating the benefits of surgery, because more difficult cases are, easier cases are treated by collagenase surgery.
That's an excellent point. The indications were different in different studies, and most hand surgeons will have a higher threshold to recommend surgery versus a more minimally invasive treatment. It's true.
Any other questions?